Hello, my name is Dr. Sugunro with Breast Surgical Oncology, and I will be presenting part two of breast disease clinical pearls. We'll discuss the history and physical exam, imaging modalities, touch on pathology, and talk about some adjuvant therapies. The history and physical is very important. The patient should be unclothed. You should do a complete bilateral breast exam, including looking at their axillary, supraclavicular, and their cervical nodes. In terms of their family history, it's important to ask about any and all relatives who may have had breast cancer, especially first degree relatives, as these pose a higher risk. It's important to ask not only about breast cancer, but ovarian cancer, prostate cancer, and pancreatic cancer, amongst several other cancers. But these ones tend to have a high rate of genetic predisposition to shared genes with breast cancer. Gynecological history is important. It's important to ask patients these questions to help kind of gauge their risk of breast cancer. So, one of the important things is knowing when a patient started menses and ended in terms of menopause. So, for example, if a patient started their period at age 9 and didn't undergo menopause until age, let's say 55, 56, they have had a longer lifetime exposure to estrogen than a patient who, say, underwent menses at age 12 or 13 and a patient who underwent menopause at age 49 or 50. So that second patient had a shorter period of lifetime high levels of estrogen exposure. The parity, you want to know if the patient is G1P1, G0P0. You want to know what their GP status is. And age of first delivery. Generally, we've looked at age of first delivery under age 30 to be more favorable versus an age of first delivery greater than age 30 to be less favorable in terms of the risk assessment for breast cancer. You also want to ask the patient, if they've used any oral contraceptives or birth control pills and how long they've used it. And if they've used any hormone replacement therapy, a lot of times patients, undergoing menopause can have a lot of different symptoms that are very difficult for them to withstand. So, for example, hot flashes, difficulty concentrating and memory lapses, vaginal dryness, a lot of different symptoms accompany menopause. And so sometimes these patients undergo hormone replacement therapy with, like a Premarin and some other types of supplemental estrogen and other hormones. So it's important to know if they've used these and how long they've used these, because these can also increase the risk of breast cancer. And also, if the patient has undergone any fertility treatments, this can be important because the estrogen supplementation or progesterone supplementation during these fertility treatments can also confer a risk. So it's important to know what type of treatments they had, how long they've had it, and use that as part of the risk calculation. Social history, it's important to know if the patient is a smoker, if they are an alcohol user, if they take a lot of caffeine. Particularly smoking on the surgical side is important because wound healing is really impeded by smoking. It's important to know that, especially when you're planning the patient's surgery. For example, if this is a patient that wants reconstruction, after mastectomy, for example, it's important for them to know that they'll need to quit smoking because they won't heal well and they'll have increased complications such as infections or wound dehiscence, etc., by continuing to smoke. Caffeine intake is an important one when we talk about breast pain. Mastalgia is an important complaint that patients a lot of times come to your office with. And one of the main things that can induce breast pain or continue to cause breast pain is caffeine intake. So that's one of the first things that we counsel patients on stopping when they have cyclical or chronic breast pain. The ECOG status. This is something important, not just for breast surgery, but really for any kind of physical assessment that you want to do of your patient to know what their level of functioning is. So it is by the Eastern Cooperative Oncology Group, and it basically assesses the patient's level of functioning and is a standardized scale that if you go to one state versus another state and you say this patient is an ECOG 1, they're an ECOG 1 regardless of where they are. So it's a standardized scale. So a grade 0 is someone that's fully active, able to carry on all pre-disease performances without restriction. So that's kind of your typical patient, right? Usually maybe your younger patient, your goes to work every day, can go up and down the stairs, can pretty much function, bring themselves to the doctor's office and everything. Moving up to grade one, this is a patient who's restricted in their physical activity, but they're still ambulatory. So they can still walk, they can still do some light sedentary things like some housework or some office work, but they're not going to be, carrying large loads or doing these things for a long period of time. Then as you move up, you have two, three, and four, and this increases the level of disability the patient may have. And to the point where you get to an ECOG of 5, and that's obviously a patient who's dead. So you most likely will not be seeing that in your office, but it's important to know your ECOG score. Why? Because when we're talking about some of the adjuvant therapies, maybe sometimes the type of surgery that we're going to be offering the patient, it's important to know, is this a patient that's going to be able to get up and walk and move around and function well on their own? Some of these chemotherapies and radiation therapy we're giving to them, if they're a really high ECOG score, their prognosis may be poor and they may not do so well. So it's important to document this in your history and physical, because it's part of the assessment we use when we're talking about the overall treatment of the patient. Now, breast cancer risk. The typical or classic model that you all have probably heard before is the Gale model. And the Gale model is a good model that has been used historically to assess breast cancer risk. The Tyrer-Cuzick, or the IBIS, the International Breast Cancer Intervention Study model, has been a little bit more inclusive of some other factors and is more standardized in our breast cancer risk assessment nowadays, not only in breast surgery, but in radiology, radiation oncology, and in medical oncology. So this is kind of what will help really standardize the breast cancer risk across those specialties that we use now. So the IBIS score is a 10-year risk of breast cancer and a lifetime risk of breast cancer, looking at multiple different factors. Now, if you look at this image on your screen here, I've actually taken a screenshot from the IBIS risk calculator. So you can go into Google and you can type in Tyrer-Cuzick IBIS calculator, and you'll get a bunch of different online calculators. This particular one is one that you can download onto your computer and have it available to use, and it's free. And by using this one, you actually can bring in a lot of other factors and look at multiple family members, which is really nice. So I've included this screenshot for you. Some of the factors that we're looking at include age, body mass index, the age of menarche, obstetric history, age of menopause, the history of previous biopsies. So that's one thing that this takes into account that other models haven't really in the past, but it takes into account previous biopsies that may have had hyperplasia, or LCIS, or atypical ductal hyperplasia. So this does take that into account, which will increase your risk. If the patient has had a history of ovarian cancer, if there's been any use of hormone replacement therapy, and it takes into their account their family history, and you can put multiple different family members in it. So I think this is really nice, and it's a very good tool to become familiar with, because it'll help you counsel your patient, right? If your patient has, 3 or 4 or 5 times, the risk of an average woman her age of developing breast cancer, that might be something you discuss with the patient, because they may be more inclined towards one particular surgery over another. Right? Someone who has a low lifetime risk with, let's say, one of those lesions that we talked about, that has proliferative aspects of it, but is not atypia that we can watch. Well, if the patient has a very high lifetime risk of breast cancer, and the anxiety induced by just observation is going to be too much, that may be an indication for you to go ahead and do an excisional biopsy on that versus observation and things like that. So our decisions when we talk about the treatment of a patient are never just one size fits all, right? We take the individual patient and we look at everything. And one of the big things that we do is a cancer risk assessment. So this is very important to be aware of. Now, along those lines, one of the things that increases our risk significantly is family history, or family history of genetic mutations, right? So the NCCN, the National Comprehensive Cancer Network, is a very important network that you should be aware of. a lot of our management protocols and our management guidelines for breast cancer and really any other cancer you can find on their website as well is through the NCCN. It's very standardized and it's something that all clinicians refer to, not just surgeons. So it's not great for not just learning about staging, which I spoke to you about in a um, previous lecture, but it's also important to learn about indication for genetic testing. So the NCCN guidelines change periodically, sometimes 2 to 3 times a year. This is the most recent as of November 2021. They have their 1.2022 guidelines for hereditary cancer testing. So the criteria for testing someone, which basically insurance companies and other payers kind of fall behind. If these are the national guidelines, then these patients usually get their genetic testing covered and paid for. So, really, any patient who is diagnosed at age 45 or less, a patient that's diagnosed between age 46 to 50 with any of the following. If they have an unknown or a limited family history, this happens a lot in patients who, may have had a family member die when they were very young, patients who are adopted or orphan patients, they may not know all of their history. And it's important that patients who are in that age range that have multiple primary breast cancers, or they have more than one close blood relative that also has breast, ovarian, or prostate cancer. Another interesting thing to look at, I mentioned in the previous things you want to collect in your history, are those family members who have had ovarian cancer, but also pancreatic cancer at any age, right? If the patient is greater than or equal to 51, it's important if they've had any of those other cancers to consider genetic testing because there are some genes that overlap between those disease processes. Um, Patients who have had more than two close blood relatives that have had either prostate cancer at any age. And another interesting thing is any age. So this is not an age dependent thing. Any patient with triple negative breast cancer, so whether they're diagnosed at 38 or they're diagnosed at 68, they recommend doing genetic testing or they meet criteria for genetic testing. This is actually a recent change because just a few months ago, triple negative breast cancer was only an indication for genetic testing under a certain age. So now there is no age limit. So that is a new update as of recent. So that's kind of the gist of some of the things to consider when you are assessing your patient. Is this a patient that would be a candidate for genetic testing? Now, it's important to know that when we say genetic testing, we're not just jumping right to the blood work and the patient getting their labs drawn. There's actually genetic counseling that occurs before genetic testing. Genetic counseling is done by genetic counselors, and these can be individuals who are graduate level trained genetic counselors. And sometimes you have nurses and other advanced practitioners that have been trained in genetic testing that can do genetic counseling. And what happens during this visit, it's typically about an hour long. And this visit really just goes through the patient's history as well as their family history with a fine tooth comb to identify any other particular areas that may be risks for genetic predispositions. So, for example, going through a patient's history and seeing if they have any family history of being an Ashkenazi Jew, right? Because we know that this population has a higher predisposition to several diseases and particularly breast cancer. So, it may be one of those things where they said, well, my great great grandmother was Ashkenazi Jew, but I didn't even think it was important during that genetic counseling session. Usually, those are some of the things that the genetic counselor will help us uncover. So, that's really great. So, now let's talk about some imaging modalities. So typically we use mammogram, ultrasound, and MRI. Mammograms, they come in screening or diagnostic. The screening mammogram is our routine mammogram that patients over age 40 start to get, and that's for your patient who is just of average risk. You don't suspect a mass, they don't have any particular breast complaints, and they don't have a reason for you to believe there would be anything there other than the fact that they're a woman of average risk. A diagnostic mammogram is usually done following a screening mammogram. If a screening mammogram sees a concerning area of calcifications, an area that might be a mass, then they'll recommend a diagnostic mammogram. Now, a diagnostic mammogram can also be performed if the patient, for example, has a palpable mass or the patient complains of discharge. If there's a patient related complaint, we usually go to a diagnostic. An ultrasound often accompanies a mammogram. So, a lot of times when a patient is getting a diagnostic mammogram, they're usually getting an ultrasound to help identify the area of concern as well. MRI is not the first line test, and it's not always ordered on breast cancer patients as part of their workup. There are certain indications for an MRI, and the list kind of grows, every few years, and it's really an independent clinical decision as to whether or not you get an MRI. But some of the classic or common times to obtain an MRI is if you have a patient who has multifocal or multicentric lesions, right? So there are lesions on multiple aspects of the breast, and you want to make sure that you're identifying those areas correctly in your surgical planning. And also, you're looking at the other breast to make sure that you don't have any synchronous or contralateral breast cancers as well. Another indication for MRI at times are patients who have implants. Mammography and ultrasound can be used to evaluate the breasts in patients with implants. However, sometimes the implants can cause some artifact on that imaging, and MRI has tended to be a more common or valuable imaging modality for those patients with breast implants. So screening mammograms, this tends to have two views, an MLO, which is a medial lateral oblique, and a CC, which is a craniocaudal. In a diagnostic mammogram, you have multiple different imaging views, and some of the common ones that you'll see in the diagnostic are the ones you'll see in the screening, so MLO and CC, but in addition, you can see like a lateral medial, a medial lateral, different magnification views or spot compression views. And these are important because they help zone in on that area that might be of concern. So here's a mammogram in the right MLO view. If you notice, when the breast is compressed in a medial to lateral motion, the breast is compressed in a horizontal direction. This allows for the superior and inferior aspects of the breast to be visualized well. So when the breast, again, is compressed this way, right, then we're able to see the superior and inferior aspect of the breast a lot better. So here's a breast that you can see in MLO again. The top aspect is superior, the bottom aspect is inferior in your MLO view. Here you can see a right and left breast together in their MLO views. And you can see a few different things in this. And I've tried to point out some of the important anatomy for you here. So you see the pectoralis that I have up here. So that's that pectoralis making that angle here. Okay. You can see the nipple here, here. And you can see glandular breast tissue. Okay. Breasts that are more dense tend to have more white, and breasts that are more fatty are more of the dark gray. So you can see that this is a patient who has fibroglandular breast tissue and relatively dense breasts. She is younger. Now, if you look closely, you can also see an axillary node up here. You can identify the nipple, and you can see different surgical clips as this patient has had previous excisional biopsy and instrumentation. This is a craniocaudal view where the breast is compressed in a cranial to caudal motion. This compresses the breast in a vertical direction. This allows for the medial and lateral aspect of the breast to be visualized well. Again, you can see the gray over here indicating fat and the gray over here including a mass that has a high density area. So this is dense tissue with something that looks circumscribed in there. When you're looking at the breast in this craniocaudal view, you are able to see the lateral breast up here and the medial aspect of the breast over here. Here you can see a right and left breast together in craniocaudal view. In this view, you can see a mass on the left side with associated clips in place. This is the ultrasound of that patient, and it's showing a mass. In this image, you see a 2.7 centimeter oval mass with mixed echogenicity of solid and cystic components. You can also see color Doppler flow imaging showing that there is vascularity within the solid component. That's one added benefit of ultrasound. Breast cancer staging. So the TNM system is what we use to stage breast cancer. T for size, N for nodal status, and M for the presence of metastasis. Stage 0 is carcinoma in situ, so DCIS is considered stage 0 breast cancer. Stage 1, 2, 3, and 4 progressively get worse. For the sake of conciseness of this lecture, I decided not to include every single stage and go through the breakdown. I want you all to visit the NCCN website for the most updated staging algorithms. In summary, know that the lower the stage, the earlier the tumor and the earlier the cancer, versus the later the stage, usually the more advanced disease. Stage 4 is metastatic disease. The American College of Pathologists have put together rigorous guidelines for how tumor pathology should be reported. This includes looking at the histological type, the tumor size, margins, lymphovascular invasion, and lymph node involvement. So it's important to know these things when you're looking at a pathology report. Biomarker analysis is also performed, particularly for the hormone receptors, estrogen and progesterone, and HER2/neu. The proliferation index, or the Ki-67, is something that you'll see on path reports quite commonly, and it's a measure of cellular proliferation. So it can go from 1% to 100%. A tumor at 1% is very slow growing. That means that the cellular proliferation is quite slow versus something that has a Ki-67 of 80 or 90%. That means that tumor is growing very, very fast. It's important to know that when you first get the pathology report back from like a core needle biopsy, for example, you're not immediately going to have the receptor status. These have to be tested for, and usually they take some days to come back. The estrogen, progesterone, and HER2 will be evaluated by the pathology lab and reported. And usually they're reported with a percentage. So they look at the amount of staining that the cells have for estrogen receptors, progesterone, and HER2, and they'll report that as a percentage. So over here, you can see that this patient had estrogen receptor positivity with 95% of those cells. So that's good. That means majority of the cells expressed estrogen receptors. Same thing for the progesterone here. They were positive, and the amount of cells with positivity were 95%. Now, moving to the HER2, this patient did not express any HER2. Now, the negative score is a 1 plus. That may be a little bit confusing. So, when you're talking about HER2, when you see a score of 1 plus, that's negative. When you see a score of 2 plus, that is equivocal, which means that they can't rule in or out whether or not this patient is HER2 positive. When you see 3 plus, that tumor is definitively positive for HER2. If the patient is equivocal with the immunohistochemistry staining, which is what is done for these markers preliminarily, then an additional testing can be done with FISH to identify if the patient is truly HER2 negative or positive. Pathological grade looks at the histological differentiation and aggressiveness of a tumor. Grade 1 is something that is given a score of about 3 to 5 on the Nottingham scale, and this is something we call well differentiated. A grade 2 has a score of 6 to 7 and is moderately differentiated, and a grade 3 is a score of 8 to 9, and that is poorly differentiated. So you might see well differentiated, moderately, poorly identified in a report, or you might see grade 1, 2, or 3. So it's important to understand the relationship between the two. Adjuvant therapies. This is important to understand because surgery is only one of the modalities that's used to treat breast cancer. Adjuvant therapies such as chemotherapy and radiation are very important aspects of the treatment. Now, it's important to know that neoadjuvant, that term refers to generally before surgery. It really means before the main treatment, where a lot of times we consider that to be surgery. So neoadjuvant means it comes before surgery, and adjuvant means it comes after. Chemotherapy, endocrine therapy with tamoxifen and aromatase inhibitors such as anastrozole, immunotherapy, and radiation therapy generally comprise the adjuvant therapies. Chemotherapy is indicated for tumors that are greater than a centimeter or positive nodes, as well as triple negative breast cancer and metastatic disease. I have on here some general treatment algorithms for pre and postmenopausal patients. I'm not going to go through every single scenario, but they are here for your reference. But it is important to know that aromatase inhibitors are usually our adjuvant endocrine therapy that we use in our postmenopausal population. Some of the indications for radiation include T4 disease or chest wall and skin involvement, T3 disease, which is tumors greater than 5 centimeters, but also T3 with N1 disease, which means they have 1 to 3 nodes positive. Also, if the patient has had chemotherapy and still has residual disease, that's also an indication of radiotherapy. And there are some relative indications for radiation therapy as well. This is usually discussed with the patient with shared decision making, as studies have come out and showed that there are a lot of different nuances and things to consider when discussing radiation therapy with our patients for risk benefit analysis. So, a patient with T3N0 disease, as well as a patient with micromets on their nodal biopsy, it's important to risk stratify these patients and discuss options with them. Shared decision making is allowing the physician to speak with the patient and help them be involved in their medical care for the decisions that they make. I have here the NCCN guidelines for invasive breast cancer that really just kind of talks about the workup. We've hit a lot of these topics today, but I did want to use it as just to wrap it up. So, putting it all together, breast disease and breast cancer is a well studied field based heavily in evidence based medicine. These lectures provided are just an introduction into the field, and I recommend keeping up to date on the topic. And it's one of those things that being familiar with the NCCN guidelines will help you stay current. I have here just one page from the large NCCN guidelines for breast cancers. This slide is very helpful to summarize the workup of a patient with breast cancer. History and physical imaging, pathology, and biomarker review, discussing genetic testing, discussing fertility, especially in younger patients, and always assessing for psychosocial needs are all important aspects of the care of breast cancer. Always remember that breast cancer is a multidisciplinary disease because it's a multidisciplinary problem. So always talk to your colleagues and talk to your team that's helping to take care of the patient. And of course, always include your patient in the treatment plan as well.